Hello students, myself Dr. Maddineni Srinivas, your dermatology faculty in this wonderful Cerebellum Academy. So in this video, we are going to see the recall MCQs from dermatology, which appeared in the UPSC 2024 examination. So let us begin our discussion with this first MCQ. You need to identify which of the following statements is characteristic of purpura fulminans. Remember students, purpura fulminans, it is a progressive condition which is going to manifest over the skin in the form of ecchymotic lesions, and it is associated with infections, and most importantly you need to remember it is associated with disseminated intravascular coagulation and sepsis. So option C, which says it is an autoimmune disorder and never associated with any infection, is absolutely wrong. Option D says asplenic patients are protected and do not develop this. This is absolutely wrong statement, students. I know that you all have this concept that asplenic patients are at increased risk of developing infections with organisms which are capsulated, like for example Neisseria meningitidis and Streptococcus pneumoniae. So D is also wrong. Option A says non-hemorrhagic bullae usually present over extremities. So remember students, petechiae, purpura, ecchymosis. I hope all of you remember these are the primary skin lesions which are due to the RBC extravasation into the skin. So if you look at this picture, you will remember that this is a purpura fulminans lesion where you are able to see there is ecchymotic lesion which is having irregular borders, and at the center you are able to see there is a bulla, and this bulla is going to have the red blood cells. That is, we can say this is a hemorrhagic bulla which we can see in the purpura fulminans. So option A is also wrong. So what is the correct statement here? It presents as large ecchymosis with irregular shapes. That is the correct statement for this MCQ. Okay, I hope it is clear for all of you. Right. This is the next MCQ. Very classical description given as it is. Okay, if you know, you know, otherwise you cannot answer. So, a elderly male presents with papular lesions on the face. So, whenever you see this elderly male with who are having these lesions over the face, so remember, think of the diagnosis most likely to be a malignancy, because usually elderly individuals are the ones who are associated with malignancies. Okay, so the papules are pearly and telangiectatic border is present, and the skin is sun damaged skin. So what is the likely diagnosis? Please remember student, this is a very classical description for basal cell carcinoma. So I will show you the images. So this image is a basal cell carcinoma. You are able to see that it is a pearly white nodule which is having the surface telangiectasia. What are telangiectasias? They are dilated blood vessels. So dilated blood vessels are called as telangiectasias. And you can see this is a more beautiful picture of the basal cell carcinoma, where you are able to see the lesion which is present above the line joining the angle of the mouth and the tragus, which is the common site for the BCC. So this is yet another picture of the basal cell carcinoma, which is showing this beautiful pearly white nature, and also you are able to see the telangiectasias, that is dilated blood vessels are also seen, and this is having beaded border. Very important, another technical term associated with basal cell carcinoma. And this condition is not going to undergo metastasis, but the problem is that it will outgrow the blood vasculature, because of which there is going to be ultimately a ulcer which will be formed, which is described as rodent ulcer, because the skin will be destroyed and damaged, just like a rat eats the skin. So it appears like that, so it is called as a rodent ulcer. And one more term which we need to remember is this ulcer is going to have rolled out edges. Okay, all these are very important previous year questions. You need to have an idea of all these terms related to BCC. Next, one more option was melanoma. Melanoma is going to be presenting as a pigmentary skin lesion which will have the ABCD features. So the lesion will be asymmetric, borders will be irregular, color will be varying in different quadrants of the lesion. Diameter will be more than 6 millimeters, and there will be history of evolution of the lesion suddenly. That is, there is color change, or there is a lesion undergoing ulceration. So these are the ABCD features which will help in the diagnosis of melanoma. Next, we have this squamous cell carcinoma. Squamous cell carcinoma, just remember, it is going to present as a papillosquamous lesion. Papillosquamous lesion initially, that is, it will present as a papules or plaques over the face, sun exposed areas associated with scaling. But ultimately, it is going to undergo ulceration. It is going to undergo ulceration, and which is going to have everted edges. Okay, this is about squamous cell carcinoma. Now coming to actinic keratosis. Remember, actinic keratosis, the patients are going to have the lesions again over the sun exposed areas. That is a phase which can manifest as papules and plaques having scaling. So we can say papillosquamous lesions will be present over the face. Okay, so these are the four options. So we have discussed each of them one by one. I hope everyone is having clarity now. So next question is, allergic contact dermatitis is a manifestation of very easy question. I hope all of you have marked this correct. So please remember, allergic contact dermatitis, it occurs where the skin is going to show inflammatory changes due to contact with certain allergens. They can be hair dye, in which PPD is the allergen. It could be due to the neomycin neosporin, or it could be nickel, or it could be potassium dichromate. So all these allergens are going to produce inflammatory changes of the skin, which is called as allergic contact dermatitis. And yes, type 4 hypersensitivity reaction is the underlying mechanism for ACD. That is the reason why, if you remember, the principle behind the patch test, is identification of type 4 hypersensitivity reaction, which is also called as, so I hope all of you know, this is also called as cell mediated immunity or delayed type of hypersensitivity reaction. Okay, about other options, type 1 hypersensitivity reaction, remember the examples with the help of the alphabet A. So anaphylaxis, asthma, and allergic rhinitis. These are the examples for the type 1 hypersensitivity reaction. So in the type 2, remember, it is associated with cytotoxicity. And what is the important example which you might be remembering? So autoimmune hemolytic anemia. Type 3 hypersensitivity reaction, I hope all of you know, this is associated with immune complexes, immune complex deposition. And what is the important example from dermatology point of view? It is associated with leprosy, that is type 2 lepra reaction. I hope all of you know this concept of rule of 5. So type 2 lepra reaction and type 3 hypersensitivity reaction, both of them, if you add, you are going to get 5. So type 4 hypersensitivity reaction, the important example you need to remember is lepra reaction, which is type 1 lepra reaction. So 1 plus 4 is going to give us 5. Okay, these are some of the important points related to the Jellicoe's classification of hypersensitivity. This is another question. So very simple question if you know the concept. Otherwise, it is very difficult if you don't know. Which of the following is a non-scarring alopecia? So I hope all of you know, scarring alopecia is associated, is also called as cicatricial alopecia. And non-scarring alopecia is also called as non-cicatricial alopecia. And remember, instead of mugging up all the cause for scarring alopecia, if you remember non-scarring alopecia examples, that will be very simple. So let me put out what are all the conditions which are non-scarring type of alopecia. That is hair loss where there is no scarring. What it means, the hair which is lost is temporary and it will again regrow. Okay, so what are the examples? Please remember, alopecia areata, anagen effluvium, androgenetic alopecia. T, telogen effluvium, tinea capitis, trichotillomania. So these are the conditions which are very important for you to remember. If you observe carefully, what is the common thing for all of them? The common thing is that the alphabet A and T are the ones with which the disease names are starting with. Okay. And also in the tinea capitis, remember black dot and gray patch are associated with non-scarring alopecia, whereas Favus and Chirion, they are also types of tinea capitis, but Favus and Chirion are associated with scarring alopecia. Okay, so answer here is obviously we have discussed so much. It is telogen effluvium, which is a diffuse type of hair loss, which we are going to see after 3 months of any stressful condition. Like for example, it could be COVID-19, or it could be like exams which are giving. So after this stressful condition, after 3 months, if there is a hair loss, that is telogen effluvium, because of the conversion of the anagen hairs into the telogen hairs. Telogen hairs only stay for a period of 3 months, and after that they will be shut off. So that is the reason why we'll see hair loss in telogen effluvium. So coming to other options, so let me just show you images of them. So linear scleroderma. Linear scleroderma, you can remember it is also called as N-Coupe de Saber, where it appears as if someone has struck the face and scalp and the face with a sword. That is the reason why it is called N-Coupe de Saber. Saber is sword. So you are able to see here the depression is present over the forehead, and also there is a loss of hair which is permanent in nature. This is an example of linear scleroderma. Okay, next we have cutaneous metastasis. Cutaneous metastasis is also associated with scarring alopecia. Okay. Next condition is sarcoidosis, which is a multi-system granulomatous condition which will produce non-caseating granulomas, and it is also associated with scarring alopecia. So please remember, these are the important ones which are given in this question in the form of options. Okay. Oh, next is this MCQ. So if you know single point, you could have easily answered this question. Otherwise, it is very difficult. So you need to identify the correct statement with respect to scabies. Okay, let me start from the fourth statement. So pruritus intensifies at night and after shower. This is absolutely correct. In the night time, why is the pruritus more? Because the female Sarcoptes scabiei hominis mite is going to burrow into the skin. And if there is a hot shower, the mite will not like it, and it will even further move inside the skin. So pruritus will increase, and that is the reason why we call it as nocturnal itching, if you remember in the case of scabies. Option 3, that is third statement, says permethrin 5% is used for the treatment. Absolutely true. Norwegian scabies occurs in immunodeficiency deficient patients. Absolutely true statement. But statement 1 says male mite are commonly transferred from an infected person to a non-infected person. No, this is wrong. See, it is not male mite, it is female mite. So this statement is wrong. So what is the answer then? So this is there, 1, 1, 1. All these are wrong. So the answer is going to be option D, that is 2, 3, and 4. So this is the female mite, which is going to dig the burrow, and you can see the babies are following the mother. Okay, in the burrows. So these are called as burrows. which are the pathognomonic lesions seen in scabies. These are the special lesions. And you can see this is a treatment, permethrin 5% cream, which is used. And this is a patient who is having the Norwegian scabies, which is also called as crusted scabies. Okay, Norwegian scabies is also called as crusted scabies, where due to the immunodeficiency or due to the reduced sensory perception, the patients are not going to have this scratch or itch sensation, because of which the mite is going to proliferate so much that there will be millions, yes, millions of the mites over the body, which will clinically manifest as hyperkeratotic scaly blocks, almost involving entire body. Or this can also be seen not only in immunodeficient individuals but also in the patients of leprosy or the individuals who do not take care of their hygiene. Okay. So this is the next MCQ. Haberdens notes are present mainly in. Haberdens notes are present mainly in. So I hope all of you know the answer for this question. Yes, it is osteoarthritis. Okay, I will show you the images. Osteoarthritis. We are having two types of named notes. So one is Haberdens notes and another one is Bouchart's notes. So how can you remember this? So basically what are these? Osteophytic outgrowths which will occur. In the case of Haberdens notes, they are going to be seen in the distal interphalangeal joint, whereas in the case of Bouchard, they are going to be seen in the proximal interphalangeal joints. Okay, so you can remember it as Haberdens notes for high. So the nodes are present high above. So high is distal interphalangeal joints, and Bouchard's nodes are seen below. That is proximal interphalangeal joints. Okay, so this is how you can briefly remember these nodes, Haberdens and Bouchards. So about the other options, so here you are able to see the inflammatory changes of the great toe, which is associated with gouty arthritis due to hyperuricemia. This is also called as podagra. And here you are able to see this is a patient of psoriatic arthritis, which is going to manifest as sausage shaped lesions, or we can say sausage digits. That is the like hot dogs, the entire finger is going to appear, so it is called as sausage digits in the case of psoriasis. So there is one simple trick for you to remember the Haberdens and Bouchards notes with the help of this famous celebrity. I hope you know who is this. Bipasa. Okay, oi, you are looking at the HD image of Bipasa. Okay, you are looking at HD image of Bipasa. So here OA is osteoarthritis, H is Haberdens, which is going to involve the distal interphalangeal joints, and B is Bouchards, which is going to involve the proximal interphalangeal joints. So I hope with the help of this you can remember OA. You are looking at HD image of Bipasa. You can remember all these notes where they are present. Otherwise, Haberdens high, Bouchards below. This is the last question. A patient suffering from which of the following condition commonly present for several years in the dermatology OPD with eczematous or dermatitis skin lesions before being finally diagnosed with a T cell lymphoma. This is very characteristic and interesting clinical scenario which the examiner actually gave you. So if you know single point, you can answer, you can mark the answer, but otherwise it will be difficult. So remember, mycosis fungoides is also called as cutaneous T cell lymphoma. So if you know this, you can easily answer it as mycosis fungoides. Otherwise, if you remember, mycosis fungoides is having 4 stages. So initially there will be a patch stage. There is going to be a patch stage, and then there will be a plaque stage, and there is going to be a tumor stage, and finally there will be erythroderma. So these are the 4 stages associated. So in the patch and plaque stages, the patients might present with the dermatitis changes over the body. dermatitis changes over the body, which may be confused for years together as simple eczema or dermatitis and treated with only topical steroids. But one fine day, the patient may land up into tumor stage or even worse, erythroderma. So that is the reason why when any elderly individual is presenting with dermatitis like skin changes, always try to do multiple biopsies if needed and try to rule out the mycosis fungoides. Okay. And one more point, I hope all of you know, in the histopathology of the mycosis fungoides, we have this collection of the atypical T lymphocytes in the stratum spinosum, which are called as Poutrier's microabscess. Poutrier's microabscess. And I hope all of you do remember, in the case of psoriasis, we have the collection of the neutrophils, which we call them as Munro's microabscess. Munro's microabscess. So if you remember, P for M and M for P, that is, in psoriasis we have Munro's microabscess, and in the mycosis fungoides we have Poutrier's microabscess. Okay.